So let's get started. Alrighty, welcome everyone to this week's installment of AMSSM's National Fellow Online Lecture Series. My name is Matt Wise. I'm an assistant professor in family medicine and orthopedics at UT Southwestern. Before we get into our topic for tonight, I want to remind everyone of next week's lecture on facial trauma and laceration repair, which will be given by Dr. Roberto Martinez 1 week from today at the same time. For tonight, I'm very excited to welcome Dr. Ryan Nussbaum to speak to us on biomechanics in the throwing athlete. Dr. Nussbaum graduated medical school from Lake Erie College of Osteopathic Medicine and completed his PM&R residency at Northwestern University in Chicago. He then went on to complete sports medicine fellowship at the University of Pittsburgh Medical Center, where he currently serves as the fellowship program director, as well as team physician for Duquesne University. Before we get started, we also like to mention the goals of the National Fellow Online Lecture Series, which are to serve as an adjunct to your individual program's educational content, to provide fellows with direct access to educational experiences with AMSSM members and at times invited guest experts, and lastly, and most importantly, to assist in CAQ exam preparation. Some reminders to please mute your device's microphone and turn off your video. Submit questions through the chat function. I, as your moderator, will ask the questions during the Q&A at the end of the lecture, and then please complete the evaluation at the end of the lecture. Lastly, one of our new efforts is to facilitate more input from our audience. There are a couple of ways to do this. First, a web link can be found by going to amssn.org, click the Education tab, and then select Fellow Online Lecture Series. The link is near the top of the page as seen in this screenshot. Second is by scanning this QR code. It should take you directly to the form that we saw on the previous slide. When filling out the form, we ask that you please keep in mind that the primary goal of this series is to assist in CAQ preparation for fellows. Now, without further ado, please welcome Dr. Nussbaum.
Thanks for tuning in. Thanks for listening to this, and thanks for the opportunity and introduction. And so I'm really lucky to be at the University of Pittsburgh Medical Center. We've got a great sports medicine group, and so we have our own fellowship program in PM&R, but we also collaborate very closely with primary care sports medicine, directed by Dr. Jeannie Doperak, and with family medicine and then we have our orthopedic colleagues. So it's a great place to practice. And like Matt said, I help with Duquesne University, which is a school in the Atlantic 10. And we definitely treat overhead throwing athletes, including, let's say, volleyball fits pretty closely into that category, and then swimming and the occasional track and field event, and like football quarterbacks, I think, qualify as well. And so we're going to keep this pretty foundational today. So we're going to talk about the concepts of the kinetic chain, talk about a foundational understanding for the biomechanics and common errors in the throwing athletes pertinent to the CAQ-SM, and then also look at some concepts that come up, particularly on boards, but also in real life. So the glenohumeral internal rotation deficit, also known as GERD, and scapular dyskinesis, and then talk about some examples of real life applications for throwing athletes where you can assess biomechanics and potentially help with optimizing them. And a lot of the emphasis is on baseball throwing because that's what seems to show up on the boards, at least when it comes to biomechanics. But a lot of this is applicable to all other throwers. So just a quick fun fact about me. I was a student manager for the University of Arizona baseball team from 2009 to 2013. The 2012 team won the national championship, so it was great, and saw really high quality baseball from a different lens. I thought I was going to go into coaching, and so that was going to be my route: student manager, grad assistant, things of that nature. But ended up going into medicine and coaching residents and fellows instead. And I coached T-ball too. But so I think the big takeaway that I think I still apply to what I learned there, and I think that applies to what we do daily, right, is this idea of you're trying to help the student athlete, and you have to be able to navigate effectively the conversation with the coaches as well as the conversation with the student athlete, athletic trainer, and make sure everyone's on the same page, which I think we all know is pretty challenging. And so when it comes to something like biomechanics, right, a coach is going to have their own thought on it, and and we have the challenge of attempting to help with that and potentially optimize biomechanics. But I think it's a real skill to acquire the trust of the coach, to offer your insight, and then how do you effectively articulate that to the student athlete so that they will optimize their biomechanics and throw, right. And maybe it's too late by college, right? Or maybe it's a little harder. But these are just thoughts to keep in mind, and I'm sure people already have experience on the call with these things where sometimes it's not that easy. So, and you may already be aware of this, but we have many outstanding lectures already within the AMSSM YouTube channel on various similar topics that we'll probably have a lot of overlap for tonight. So, kinetic chain and biomechanics in the athlete, shoulder and scapular conditions in the overhead athlete, overhead injuries and prevention, the overhead athlete symposia, a discussion on the throwing injury epidemic in baseball and softball, and then non-surgical management of medial elbow pain and throwing athletes, all very pertinent and a nice overlap. So kinetic chain theory, I'm sure we're all familiar with this, and really the picture on the right summarizes it very well. So ideally, you have this energy that starts in the legs, right, and it works up ultimately to the wrist, and as you're generating this energy, it tends to become higher and higher the farther out it goes distally, and so this is thought to each of these areas is thought to be sequentially connected and coordinated to transfer that energy with an ultimate ball release or javelin release or whatever sports being played. And so there has been some percentages looked at this. And so for a thrower, the lower extremities and core tend to comprise 50 to 55% of the total energy, with trunk being roughly 20 to 25%, and the shoulder and arm being about 20 to 25%. And I think we all understand that if you have an underperformance in the proximal segment, that could result in an overcompensation of a distal segment in an injury. And I really think that's the core to this talk, or core to just biomechanics in general, is looking for where the breakdown occurs. And we've probably all been in the training room, or we've all been in clinic where you're working with a high level thrower or overhead athlete and they have shoulder pain. And I think probably what I learned early on is that this is hard. And so what I mean by that is the answer is probably not in the MRI, right? The answer may be in the last 5 to 10 years of how they've trained, and maybe in how they're generating force through their body. And I think having a really good understanding of the biomechanics can help you potentially find an area for improvement where they can further offload their shoulder with the forces that are going through there. And so, just a couple of examples that you can see in baseball pitching, but this translates to all other throwers as well. So, having a kinetic chain deficit, such as a hip weakness or reduced hip internal rotation, that could result in reduced energy generation and compensatory shoulder stress. Core weakness could result in a decreased trunk rotation or increased arm stress. Scapular dyskinesis, which we'll talk a little bit more about, there is the possibility that that could result in altered glenohumeral mechanics or a posterior humeral translation affecting how the shoulder is moving. The GERD, or glenohumeral internal rotation deficit, may alter arm position, increase joint stress. Shorten stride, that could result in an early shoulder external rotation at foot contact. And a previous kinetic chain injury could, as we know, result in a persistent mechanical alteration further down distally in the kinetic chain. So this is the classic video, or the classic image of all the different phases of pitching. And so we'll go through these in detail, but it is helpful to have a picture like this, or a video you can refer back to review these. So it's going to be a fair amount of repetition here, and there may be deficits that are called out in many of these different phases. And if you're hearing that, I think it's important to know that's probably something that can really lead to injury, or something pertinent to note that may show up on boards. So we start with wind up, early cocking, late cocking, acceleration, deceleration, and follow through. And as we're going through, it's important to know when these activities start and stop. And so we'll make an emphasis of that. So the wind up, typically that's with that typically starts with a first step. So usually the thrower will step to the side and it will stop when the ball leaves the glove, or I think probably more easier to understand is this balance point where the knee typically is at the lead knee is at the highest level of um, elevation. And the primary muscle activation here is the lower extremities. There's not much going on in the upper. When it comes to errors that are seen with this, you can see a excessive leg valgus in the stance leg. You can see insufficient lumbopelvic control of the stance leg and poor dynamic balance and an insufficient push-off force. So if you're not familiar with baseball or softball, there typically is a hard piece of a block, also known as the rubber, that you push off with your back leg to generate force. So they need to be doing an effective job of using that to generate velocity. And so now we're transitioning to the early cocking phase. So that's going to start with the balance point and it's going to end with the lead foot ground contact. And it's important to note that the stride length should be about 85 to 100% of the pitcher's height. And if you're into baseball, you've probably seen stories of people with higher stride lengths than that, like Tim Lincecum from the Giants formerly. So there's a lot of variability with that. But the increased stride length, it can result in an increased velocity. And at this moment, with another key point is that the hips need to be rotating first. So in comparison to the trunk and in comparison to the hips, the hips need to be rotating first. And you have to be able to have good hip range of motion. This is where the internal rotation deficit can come into effect. There's going to be some upper extremity activation here as you're starting to move the shoulder backwards. It's low. It's not as uh, rapid or intense as we'll see later, but the trapezius, serratus, deltoid, supraspinatus all generating here. Common errors here is the rotating of the shoulders and the hips at the same time. It should be hips first and then shoulder. And then, of course, an improper stride length or a lead knee flexion that is not ideally 45 we want it to be 45 degrees, so something different than that would be problematic. Talked about how the limited hip range of motion could result in a suboptimal pelvis rotation as well as a stride length that isn't ideal. And we want that the shoulder external rotation to be about 45 degrees with abduction to about 90 degrees when we have foot contact. So switching to late cocking here, and so this is starting with the lead foot ground contact, and you end with a shoulder with a maximal external rotation, approximately about 170 to 180 degrees. And this is where in late cocking you see the trunk rotate after the hips toward home plate. And the greater the external rotation, that can correlate with an increased speed of pitch. There is some other concepts that are known with the shoulder, and it's we're just covering this pretty superficially, but there's dynamic and static stabilizers of the shoulder. So the idea of keeping the glenohumeral joint intact, making sure the humeral head is not slipping out. You've got the subscapularis, pec major, lat dorsi, bicep, infraspinatus, deltoid, and teres minor. And they're dynamic, they're moving, right, during the action of throwing. If you just take a second and think about how they're activating, many of these are opposing each other and resulting in some balance of the glenohumeral joint. And then you also have static stabilizers, including the glenohumeral ligaments, the labrum, and capsule. And it's important to note that there's a peak valgus stress at the elbow at late cocking, but as we'll see, also at early acceleration, which is the next phase. Let's see here. So we were going into the errors here with late cocking and baseball pitching. So this one we've seen before, right? I mean, this trunk and hip rotation needs to be happening separately. Sometimes people have, there's been some description of excessive scapular internal rotation, which can be seen in protraction of the scapula, which could be not good. And then excessive shoulder horizontal abduction, decreased subscapularis strength, or an insufficient pelvic rotation, all errors that could potentially lead to an injury. So with acceleration, this is going to start with maximum shoulder external rotation. It ends with ball release, and it's very rapid. It's 2% of the total pitch time cycle. And the average at peak angular velocity of the shoulder with internal rotation is about 8,000 degrees per second. I don't think that's going to be on the boards, but that comes up pretty much in every text on biomechanics. They talk about the degrees per second with the angular velocity of the shoulder. And so understanding what's involved there. So the lat and pec major are your primary internal rotators. And again, the peak valgus stress at the elbow is seen in the early acceleration or the late cocking there. So one of the things that is talked about in the literature is this increased contralateral trunk tilt at ball release. So what if we're looking at this model of a thrower, the arm, they're a right-handed thrower and their trunk is tilted to the left. This has been described as potentially being a risk factor for an arm injury or for a throwing injury. And so again, we go back. This keeps coming up every step. Trunk rotation and hip rotation need to be good and sequential in what we've talked about before. Insufficient lead knee extension can be problematic. And again, insufficient pelvic rotation can be problematic. So deceleration, this is going to start with ball release and it's going to end with the arm achieving a 0 degrees with internal rotation. And it's interesting, they talk about shoulder distraction forces in the textbooks and they talk about it in newtons, but I feel like if we talk about it in pounds, it's more relatable. So 245 pounds, it just gives you a sense of how much distraction is happening at the shoulder with deceleration. And you got to think about the muscles that are really trying to just slow down the shoulder velocity. And so we're trying to oppose internal rotation. So we've got external rotators, right, of the rotator cuff muscles. So that would be infraspinatus teres minor. You've got scap muscles that are opposing, including serratus anterior, trap, rhomboids, and levator scapula. And errors here or concerns are having that posterior cuff weakness. It's been described that scapular anterior tilt can be a problem, which is also seen in protraction, a rushed deceleration or doing it too quickly, and a glenohumeral internal rotation deficit has also been described. And so when it comes to deceleration and follow through, there is a description of that almost being the same step and just a continuity of the deceleration, but it's the body catching up to the throwing and having the back leg landing on the ground there. You'll have the shoulder have a horizontal adduction moment, elbow extension, and forearm pronation. You'll have wrist deceleration, and there's going to be the same upper extremity activation that we just talked about. And I feel like we don't talk about the legs enough with these biomechanics, but if you just look at the front leg of this thrower, you can have a sense of what's being activated. So you have quadricep activation as you're leaning forward with your weight. You're going to have an eccentric activation of the hamstrings, and also a gastrocnemius is going to be activated. And so again, when it comes to follow through, a contralateral tilt is not ideal here. A rushed follow through, posterior cuff weakness, insufficient lead knee extension is a unique one and compared to the deceleration. So, being from Pittsburgh, we got to show our guy, Paul Skeens. And so we're going to look at his mechanics. And again, just try to watch this live with the understanding of which step is which, right? And so can you see that video?
Yep, looks great.
Okay, so remember wind up is that first step, and then early cocking is the that's going to start with the balance point, right? So that's when the knee is the highest. And then late cocking is going to start when the lead foot hits the ground. And then after that, once the shoulder's in max external rotation, that's when acceleration starts. And then upon ball release is when you have deceleration and follow through. So definitely easier to watch in slow mo. And I think going through this slide again or can be helpful to just really burn that into your memory and get each of those steps appropriately. And I would argue, you're probably covering a lot of different teams if you're in fellowship. When you land your job in your as faculty or wherever you're practicing, and you're with a new sport that you're not too familiar with, yeah, I think you've probably already realized. I mean, these coaches will talk with you, athletic trainers will talk with you to teach you the specifics of the biomechanics and what they're seeing. And I think that is a way that you can really be an advocate for your team, and then they see buy-in from you, right? And I think we all know that the care tends to be the best when coaches, athletic trainers, strength and conditioning, and physicians are all on the same page. So easier said than done, but if you have the bandwidth to commit to learning the sport, learning the biomechanics, and anything, but particularly these overhead athletes, I think it can be very beneficial. So this glenohumeral internal rotation deficit, it's talked about a lot. I think it's important to know how to measure. So typically you have the student athlete supine with their shoulder abducted at 90 degrees and their elbow flexed at 90 degrees. And it's important to have the scapula stabilized. So you're just isolating the glenohumeral motion. You'll use the goniometer as a forearm, and you rotated both external rotation and internal rotation until there's scapula motion detected. And as you see with the picture there, that's generally the arc that we're looking to review. And so there's these calculations. So GERD is you take the non-throwing internal rotation and you subtract it from the throwing internal rotation with the assumption that the non-throwing should have better internal rotation. External rotation gain. So it's thought that there can be a compensatory throwing external rotation acquired in the throwing arm compared to the what would be seen in the non-throwing external rotation. So that description of a throwing external rotation minus non-throwing external rotation is known as external rotation gain. And then total range of motion is really just adding internal rotation plus external rotation for each side, understanding the arc of motion. I think that's talked about also with the hip anatomy, and if you've had any talks on that. And so total range of motion deficit, pretty simple. You take the non-throwing total range of motion and you subtract it from the throwing total range of motion. And so with that said, I think we can go into some more discussion about these definitions. So certainly for boards, I think knowing that GERD, the most common definition is greater than 20-degree loss of internal rotation in the throwing versus the non-throwing shoulder. You'll see some further discussion in articles talking about how there can be this anatomical versus pathologic GERD. And anatomic GERD, typically there is a presence of a loss of internal rotation, but there is a preserved total range of motion where there has been an increase in the external rotation. So this could be seen in a humeral retroversion circumstance, which is thought to be adaptive, potentially beneficial. And it's thought to be pathologic when there's GERD present, and then you have a total range of motion deficit of 15 degrees. And the theory with that is that there's a posterior capsule contracture, and potentially it's modifiable. So you could to treat that. And so when it comes to why is this a problem, it has been described that having this, there's a potentially 2 times more likely to have an injury. And what I thought was interesting, and I haven't seen this too much clinically, but there's been some description of this phenomenon, and then also having atrophy of supraspinatus and infraspinatus, which you would think would really affect how someone throws, but it's described in the literature and sort of an interesting finding. The first line treatment for this is stretching to restore posterior shoulder flexibility, scap stabilization exercises, core lower body strengthening, and correction of throwing mechanics. So scapular dyskinesis, I mean, this is a controversial topic, I would say, and there's a lot of thoughts about it. So in general, 46% prevalence of all athletes having scapular dyskinesis. So that includes people who are not overhead athletes. So it's common pretty much probably in anyone, but in the athletic populations. And there's actually a scapular summit back in 2013. Dr. Kibler was one of the main authors for it. And so one of the main summarizing points from this is that it is possible that this could be an impairment to shoulder function, having scapular dyskinesis, rather than being a definitive pathologic finding. And I think what we're seeing is that there may be categories that may be more pathologic than others when it comes to the dyskinesis. So I think we're all, like we've already reviewed, if or I don't think we reviewed it yet, but we talked about, with scapular motion, there can be legitimate medial scapular winging, lateral scapular winging, when there's a legitimate peripheral nerve problem, of course that's going to affect throwing. The majority of the time, it's not that involved, and so further subcategorizing these scapular dyskinesis and understanding which ones are more pathologic is going to be important. So scapular anterior tilt, that's been described as potentially increasing likelihood of injury in throwers. But I think we got some work to do to further parse all of this out. But definitely an interesting topic. And a lot of those videos that I showed you earlier in AMSSM library touch on the scapula. Particularly, I believe Dr. Kenyon, Charlie Kenyon, had a really good talk on that. So when it comes to uh, just the clinical applicability and considerations, maybe at your university you already have some sort of pitching lab. I think it was a few years ago, the Wake Forest pitching lab really got a lot of press, and it's really impressive. I mean, they have the woman on the left. I'm not sure if she's still there, but I believe she was their lead scientist. She had a PhD that had a lot of experience, understanding of studying biomechanics and throwers. I mean, they have 20 cameras, they have force plates, TrackMan technology, a lot of these metrics, right? And it's not exactly feasible to the community at this point, but it's interesting that there's this investment in this, and it would also be interesting to see how this lab would talk with the coaching staff and the players and how they can effectively get that information implemented for benefit of the student athletes. I bet that's probably harder to complete than it seems. And so I think other technologies that are seen here, this is a mustard app, right? And so I'm not endorsing this app, but I think it's interesting to see what's out there, so you know what maybe the patients are doing to evaluate their technique, and and just understanding of the technology, right? So they're offering a same session motion analysis through an app, and then you get personalized instructions from high level coaches, typically throwing coaches. So Tom House is a pretty well regarded throwing coach who has made quite an impact in the throwing world, and he's involved with this app. And so when I was in fellowship, I was trying this in my um, just in my living room. And so you take these pictures, you do like a front profile, you do a side profile, you do three of those. They're actually videos, and the technology is watching your biomechanics, and they do this sort of analysis as you're submitting it, and then they give you a score from the 6 pitches you submitted, and they talk about various metrics, right? So they'll talk about balance, timing, stride, posture, lift and thrust, release, swivel, stack and track, torque retention. Some of this phrasing is synonymous with what we talked about. It just might be using a different phrasing. And from maybe where I failed swivel, they would give you a feedback on, well, you could do better with this. This is what we're trying to teach you, and they give suggested drills. So I mean, this was from a few years ago. I'm sure there's probably similar apps to this now, and this technology is probably going to be more available, which probably is good. It's just we'll have to study it and see how effective it is for implementing positive change. And then one initiative that I thought was really novel and potentially going to be very impactful is the pitch efficiency ratio for out of Emory Sports Medicine. This was a validated model from a tennis app created by or a tennis rating score created by Dr. Jayanthi. So the stroke efficiency rating, and so what they utilize is a 2D video collection, like using an iPhone. They have which is good, right? It's accessible technology, and then they also have 12 key kinematic variables chosen based on risk factor for injury. And in total, these people get a 36-point score. The goal is to provide feedback for improving mechanics, particularly youth and adolescent. And so I think that's a key point, right? I mean, Emory's great. I mean, they're doing work that is trying to target younger individuals where you have the potential to implement good biomechanics with the long term effect of the injury prevention, really. And this has the potential to be used with athletes, coaches, and medical staff. And so they were looking at all of these different phases as we've already talked about, and the different areas where they're scoring is, wind up. They talk about balance point, stride. They look at essentially shoulder abduction, elbow flexion, knee flexion, stride, foot angle, landing, hand position and direction, shoulder abduction, elbow flexion for caulking, and then for acceleration, shoulder abduction, elbow flexion, knee flexion, and then for deceleration they do fielding position. So it's I still think they're doing work with this. They've done some feasibility work looking at this rating, and I think it's got a lot of promise, and the idea is really great. So had some CAQ questions we could transition to here if we want. Does that sound reasonable?
Yeah, sounds great.
Okay. All right. So a 16-year-old baseball pitcher presents with medial elbow pain that worsens during the late cocking and early acceleration phases of pitching. So during which phase of the pitching motion would peak valgus stress occur at the elbow? So we got wind up, early cocking, late cocking, early acceleration, deceleration, and follow through. So, yep, late cocking and early acceleration. I mean, that's definitely one you could see, and a good. All these I tried to pick because I think they have a possibility of being on the boards. So we have a collegiate pitcher that demonstrates gird of 25 degrees in the throwing shoulder compared to the non-throwing shoulder. What is the clinical significance of gird exceeding 20 degrees? So, A, it's a normal adaptive change in an overhead athlete with no clinical significance. B, it's associated with increased risk of shoulder and elbow injuries. C, it indicates superior labral pathology requiring immediate surgical intervention. D, it improves pitching velocity and should be encouraged. And E, it only occurs in pitchers with poor mechanics and resolves with rest. So B, it's associated with increased risk of shoulder and elbow injuries. So number 3, we've got a 17-year-old high school baseball pitcher being evaluated for decreased ball velocity and increased shoulder fatigue. Biomechanical video analysis shows that the pelvis and trunk rotate simultaneously during pitching motion. So at the instant of stride foot contact, what is the optimal relationship between the pelvis rotation and upper trunk to maximize energy transfer and ball velocity? So a, pelvis and upper trunk should rotate simultaneously to maximize the rotational power. B, upper trunk should rotate open before the pelvis to increase shoulder external rotation. C, pelvis should be slightly open while the upper trunk remains aligned with the pitching direction. D, both pelvis and upper trunk should remain closed until maximum shoulder external rotation is achieved. And E, pelvis should remain closed while the upper trunk rotates open to reduce elbow valgus stress. So remember, what you got to think about is what phase we're in, right? So we have had we basically what we've got foot contact, right? So right around then, you just got to remind yourself of what phase we're in, and then what should be rotating at what manner, right? So again, it was a point we tried to drive home a couple of times there, that the pelvis, it should be the first to open, and then the trunk would then subsequently open afterwards. So it should be remaining aligned in the pitching direction, and then during um, essentially acceleration, you're going to have that turning of the upper trunk there. All right, so last one, a sports medicine physician is performing a biomechanical analysis on a 19-year-old pitcher who has been experiencing anterior shoulder pain. The physician wants to identify the late cocking phase of the pitching motion to assess for potential internal impingement. Which of the following best defines the late cocking phase of pitching? So from the initiation of the windup until the hands separate, from hand separation until the foot stride contacts the ground, from stride foot contact until maximum shoulder external rotation, from a maximum shoulder external rotation until ball release, or from ball release until maximum shoulder internal rotation. So that's the definition for a late cocking phase. And these are the references. If you message me on Twitter or So yeah, I think that would probably work best. If you message me, I can get you these references. There's a ton of content out there, and it really goes into a lot of depth. So we tried to keep it simple tonight, and then if it's really a point of interest for you, I think you could certainly uh, expand your knowledge by reviewing all these different articles. And this is our volleyball team at Duquesne, and thanks again for tuning in and reviewing the content.
Thanks so much, Dr. Nussbaum. That was excellent. I think you win the
Yeah,
award for the most number of CAQ questions this year, so great job. Um, Super practical, and I think it's nice to be able to have the time and dedicated lecture to get down to basics, fundamental biomechanics. I
yeah,
really loved how you started off the talk saying like, hey, a lot of the stuff you can't see on an MRI, right? Maybe you see the consequences of years of this
mhm,
type of thing afterward. And so, you know, from a practical perspective, you mentioned some apps, you mentioned, interdisciplinary work. How do you
mhm.
assess biomechanics in your clinical practice? And it's probably going to be different based off of what setting you're in, professional, different divisions in NC2A, that type of thing. Are you doing it
Yeah,
in athletic training room? Do you have the time to do it in clinic? Are you relying on your athletic trainers to send you videos? How,
yeah.
how does that look like in your practice?
Yeah, I mean, so I'm sure you've seen it too, Matt, right? Like you got to know what you don't know, right? So if I mean, I swim, but I've never competitively swam, right? So one example is when a swimmer comes in with shoulder pain, I know I know that my biomechanical understanding of that is pretty limited, right? So and also I want to respect the coach, right? And because they're going to have a pretty high understanding of biomechanics, and I try to say like, hey, can we do a swim analysis? Like, I've noticed that they're having I don't know, 2 or 3 months of shoulder pain, performance is dropping. Um, Classically, like a swimmer's shoulder, that MRI is going to show what? Maybe just a little supraspinatus tendinopathy, and otherwise it's going to be pretty clean, but they're having pain trying to get dressed or something pretty debilitating. So try to be systematic with it and utilize you know how it is. Like if you're at a college, at a higher level college, Division 1 resources, you can lean on the coaching staff to look at biomechanics, hopefully, and then you can also talk with strength and conditioning, see what they're seeing, see what the athletic trainer's seeing. But when you're in your office, I think it's really hard. Like I think the reality is this: like you need to build you need to build a really good team in your community, right? Like you've got to, all right, if it's a thrower, you got to have the physical therapist that gets that and that can spend the time with them, even looking at their mechanics. Do you have a trusted pitching coach in the area where you say, hey, they were at this particular level, they've done a great job with these athletes in the community, and you've got to lean on your whole team because I mean, ideally, what we'd have 60 minutes or something to look at the video of throwing, and then we'd go through like a bullpen session and but then we'd be out of a job. Like, uh, we can't just bill for that. So, really, I think the reality in a clinic is that you try to educate them on like what's the most realistic way of getting back to the performance they want to do, and you have to connect them in with the right people in the community. And doing it yourself is just not going to work.
Yeah,
Like, at least that's been my experience.
totally. No, I'm with you. I take care of a D2 school, and we've got a pretty avid baseball program, and I have the benefit of working with an athletic trainer who used to work in the major leagues. You know what I mean? So she's bringing up all this stuff, and I'm like, all right, catch me up here, because on the
Yeah,
similarly, I didn't grow up playing baseball, and so but I
yeah,
think I think with with biomechanical pathology, it's so much more interdisciplinary than, a fracture comes in, right? Or someone's coming in for an injection, right? And for better or worse, the healthcare system's not really built to support what you just described, right? That 60-minute eval where you're talking with coaches, talking with trainers. So,
yeah, yeah. I mean, I know Emory has an interesting model. You may be familiar with it. I mean, they have like physical therapists that are in their baseball medicine program.
mm,
So then they have this whole like internal track of, oh, we're the baseball group or we're the tennis group.
Yeah,
and I think they've created some version of that, which I think is pretty neat.
totally. I
Yeah,
think for those of us who aren't in a system like that, it does,
yeah,
the reason why that this is on the boards is because it's a helpful starting place when we're talking with the athletes in clinic. You know what I mean?
mhm.
And we're talking
Yeah,
about GERD and the one that comes up for me in our pictures is like, where's their follow through look like, right? All right, and do they need to drop?
mhm.
Do they need to drop their angle a little bit? Where's their trunk tilt, their anterior tilt, like you were talking about?
Yeah.
We see the rotator cuff showing up all the time on MRIs, and then it's
Mm.
this back and forth in terms of, well, how much is this contributing? Is it chicken or egg? That type of thing.
Yeah. It's tough. I mean, when they're at college, it's tough. I mean, they're pretty set in their ways. I mean, I think that's a real art to be able to modify something at that age.
Yeah.
Um, and yeah, there's a lot of dynamics there.
100%.
Mhm.
This kind of leads into an audience question from Matthew Costin.
Mhm.
He says that he hears a lot about rotator cuff strengthening, range of motion, scapular stabilization. Do you have any specific programs? I'm assuming like an online home exercise program for the scapular stabilization, or is this more deferring to our interdisciplinary team like we talked about earlier?
Yeah, that's a good question. I mean, I typically I typically refer like you have your physical therapist in the community you trust, right? And okay, that's the baseball group. And there's some really good there's some really good articles out there on this. I'm blanking a little bit on the name of it, but the group, the Andrews Institute down in the South, they have really good baseball physical therapy there, and they've created this. I'm blanking on the name of it. Um, I thought it was called the. Thanks for your patience. There was some sort of like checklist where you could check. It was actually nice. It was throwers 10, Karen with the win. That's what I'm talking about. Yeah, that's what I was trying to articulate is that throwers 10 or a revised version of that to give a framework to physical therapists. Hey, this is the approach we're looking at for a biomechanical optimization, because that's the reality. Is like it's not just the shoulder, right? It's like what's going on with the hips, what's going on with the legs. Is there something? Do they just have like some sort of significant FAI where they can't get to that internal rotation, and then they're just that's just how they're built? And so having someone who's willing to go with them on that sort of comprehensive a functional movement assessment, I think is very important. And that's kind of where I go with it. I'll do that when it comes to and really it's tough, right? It's like we probably all see runners too, right? So like you see a runner, you got to have that physical therapist that understands the return to run. Well, like the physical therapist probably needs to know the return to throw, right? And
Yeah.
I don't think that's that easy to find. Um, you know, like
Probably harder to find. I mean, I also liked kind of your description of the scapular dyskinesis and it being more of a potential impairment versus like it's not always a true pathologic finding. That reminds
yeah,
me of runner's gait, right? Everyone's got a little bit of a different gait, and it doesn't necessarily mean that it's pathologic, but there are ones that put you at high risk of injury for sure.
yeah, yeah,
So.
um, yeah, yeah.
Chris asked, what's the approach you take with younger athletes? So these would be the athletes before they get to the college level and are harder to adjust form and things. Um, when they're a little bit newer and you're trying to adjust biomechanics.
Yeah, it's interesting. I mean, I think so. You got to understand the context of who they're interacting with, and a lot of those other talks on a lot of the other talks that were in the AMSSM channel get into the other aspects that potentially lead to bad habits for these young athletes and keeping a healthy arm in general. Specifically, when it comes to biomechanics, I think the coaching's key. It's the biggest part. So who are you working with? And because that's the touch point, right? Like as a physician, we're kind of limited, right? Like, hey, why don't you come back every week and we'll throw a bullpen? Like, well, then we're the coach, right? Like, and so whoever you kind of get a sense of who they're working with, and if you can watch a video and you're like, oh, if you have a video, that's probably ideal, and maybe you give like one or two things, right, that you could give like input on, and and they would need to trust you on that. But ideally, then you have the dynamic with the coach, like, hey, I watched the video and I noticed, the contralateral trunk rotation with acceleration, and I think we've got to get them more upright. Can we work on that? And that would be ideal. I think a coach is essential, right? Like the apps where you're just filming yourself. I think the one thing is that it's kind of like AI physical therapy. Like you need somebody to cue you in onto what the appropriate movement is, and what you're actually doing. I don't know if just filming yourself and doing it by yourself will work. I think you need input from a coach, but I think you got to keep it simple in clinic. You can't give them six things to work on if that's your route, because they might just comprehend one, and then just try to translate that to a trusted coach.
Yeah. I
Mhm.
think that's a great point. Coaching, especially the form and pitching coaches, probably don't get enough credit and aren't necessarily thought of as much in terms of the interdisciplinary team. So I think that's a great point.
Yeah,
Um, Kind of one last question I have for you in terms of, say you're diagnosing pathologic GERD, you think it's contributing to pain and symptomatology. How
yeah,
how how long in your experience have you seen in terms of return to play once we've kind of established that as a contributing factor?
yeah. It's a good question. I honestly, when it comes to this, I haven't really navigated that too much, to be honest. And maybe it speaks to the reality of like practice, right? Like you're in there, you're seeing someone with shoulder pain, taking the time to measure internal rotation and doing it, and then translating that to having that be a part of the rehab, because you know how it goes, right? I mean, a lot of this shoulder pain starts when it's not in the off season, it's like mid season, and they're like, well, I have to keep playing, so what do I have to do to keep playing?
Yeah,
And uh, really, it's almost like you're trying to build towards the next off season and just get through the season somehow, with the understanding that, hey, like how much like sleeper stretches are you doing? How much like capsular related soft tissue work are you doing? Um, and so I've never seen it in the sense of like, hey, we're shutting you down with this, but I think it's like seen in a constellation of factors that could be optimized.
gotcha.
Um, I don't, have you met? I mean, have you, how are you seeing it with your baseball team? Is it like
We're
I don't
not,
know.
we're not, I'm not seeing a ton of it, and which is kind of why I was asking is like, hey, is it something more that you want to shut them down until they can restore their range of motion? But it sounds like I totally hear what you're saying is that there's a lot of maintenance that goes on mid-season, especially for our
Mhm.
younger guys, right? Like the freshmen and the sophomores who haven't been playing or pitching at this high level in the past,
Yeah.
and then they ramp up real quick. Um, so
Mhm.
so no, I think that makes sense and is consistent with what I've seen, um,
Yeah.
and probably consistent with optimizing biomechanics in general, right? It's not like
Yeah.
a full thickness rotator cuff tear, dislocation, a fracture, an acute muscle injury, right? But it's
Yeah.
optimization that happens.
Yeah. I see Rahil's question. He's asking about how do you approach dead arm syndrome, and so I would say this: like, I haven't seen this yet as a. I guess maybe I've seen versions of it in volleyball. I guess I would say, but I think this gets back to the bigger picture of the student athlete, for dead arm syndrome. There's a lot of questions that need to be asked about their workload, right? This may not just be like a biomechanical deal. This may be how many teams are you playing on? How often are you pitching during the week? Um, and what are you doing in the strength and conditioning realm? Because syndrome gets tough, right? Because here comes my dog. Syndrome gets when there's not like an exact deficit you're working on. This is almost just my understanding, anyways. It's an overuse scenario, so it's trying to get some more appropriate load for that student athlete and probably some like well needed rest is typically my understanding. But it's also an area that I haven't encountered too frequently. So but that's my general understanding of it.
That's great. Okay, I think you may have also set up for most number of questions after a talk. So thank you so much, and thanks everyone for tuning in. Don't forget to tune in next week for facial trauma and laceration repair, and hope you have a good night.